My name is Sarah Clark, and today we are going to be covering the abdominal assessment. This is Kimmy. She's agreed to be our patient today. When you do an abdominal assessment, the order you assess in is inspection, auscultation, percussion, and then palpation. You don't want to percuss or palpate before you auscultate in case you create false bowel sounds or kind of jumble things around. So you want to auscultate before you do anything hands-on, like percussion or palpation. So the first thing we're going to do is just inspection. We're going to inspect the skin color, the tone, look for any scars or lesions, stretch marks, make sure the umbilicus is centered, look at the contour of the abdomen, assess if it's flat or rounded or distended, and then assess the symmetry of the abdomen to make sure there's no masses or anything on one side or the other. You can also assess for their breathing, you'll note, or assess for any peristaltic waves from the colon and intestines or any aortic pulsations you may or may not see. So yeah, for Kimmy, all of that looks very normal. It all looks symmetrical. The color of the abdomen might be slightly lighter just because, or compared to the rest of the body, because it typically doesn't get as much sun exposure. You can also inspect for an abdominal hernia by having, sorry, I'm gonna make you do something. Just lift your head up for me. Bow your head, yep. So when she lifts her head, you would look for any masses or changes in the abdomen wall. And if you saw any masses anywhere, that would indicate that there may be a hernia in that area that's coming through the abdominal muscle wall. But that's not the case here. So the second thing I'm going to do is just auscultate for bowel sounds first. When you're doing this, you kind of split the abdomen into 4 quadrants: the right upper quadrant, left lower, and right lower. You want to listen in each quadrant for bowel sounds. Anywhere between 5 and 30 bowel sounds is considered normal. Before declaring any hypoactive bowel sounds, you have to listen for an entire 5 minutes, because it just might take that long to hear the appropriate amount of bowel sounds. So I'm just going to first auscultate on this right upper quadrant. Try and warm up my stethoscope a little bit. Okay. And bowel sounds usually sound like soft clicks or kind of like gurgling. And I heard several on that side, so for the sake of this movie, once I hear several, we'll just move on to the next quadrant. Okay, and I can hear several bowel sounds on each quadrant, so that's a normal finding. The next thing I'm going to auscultate for is for any vascular sounds or a friction rub. Vascular sounds would be like if you heard a bruit, which is kind of like a low-pitched murmur-like sound in the aorta or any of the other arteries descending from that. And then a friction rub, you'd listen over the liver and spleen, both of those. A friction rub is if the patient takes a deep breath and the liver organ is rubbing against the peritoneum. You hear that friction rub. You hear it rubbing against the peritoneum itself. So I'm going to first listen just over the aorta with the bell of my stethoscope for any bruits. And then you would move your stethoscope down on both the left and the right side to where the renal and iliac arteries split, and listen over both of those for a bruit. And then over the femoral artery as well, a little bit lower. And then repeat it on the left side. And then the femoral artery as well. Okay, and then for friction rub, you're going to listen just at the base of the costal margin at the bottom of the ribs on the right side, and then on the left. And then pay attention when the patient inhales and see if you hear a friction rub then. Okay. And I can't hear any friction rubs there. We'll do it again on the left. Okay, and that sounds normal as well. So no bruits and no friction rubs noted here. The next step is percussion. So the first thing you're going to do is just percuss the entire abdomen. Start on the right upper quadrant and just work your way around clockwise. Most of the abdomen is filled with lots of air, So you should hear a very tympanic sound, and you percuss by using your dominant hand and striking your non-dominant hand on the middle finger, and you do 2 quick strikes and then release so that you don't muffle the sound. So I apologize if my hands are cold, but first I'm just going to percuss on this right upper quadrant, and then left side, and kind of work my way around clockwise. Okay, and I can hear that tympanic sound all the way around, which is a normal finding. The next thing I'm going to percuss specifically is for the liver and spleen for their location and size. So for the liver, you start at the midclavicular line, down at the bottom of the ribs, and you percuss going upward. And where it changes from tympanic to dullness is where the bottom border of the liver is. So I'm going to start to do that. So right there is where it changes from tympany to dullness, and then you do the same thing from the upward side moving down. So I'm going to do that as well. And then you can assess the upper border as well. A normal liver size is anywhere from 8 to 12 centimeters, and that looks normal here. For the spleen, you can also percuss starting on the left side with the mid-axillary point and percuss downward, noting any changes from dullness to tympany. The spleen can be a little bit harder to percuss the borders up because it sits more posteriorly, but we'll demonstrate how it's done. So you start up high with that mid-axillary point, and then just percuss going downward where it changes from dullness to tympany. And then you can note the borders of the spleen on that side. The next thing we're going to do is to check for CBA tenderness, and that one actually, Kimmy, I'm going to have you sit up for a minute and face me. And I'm going to come on the back side here. And this one is just checking for any, sorry, I'm going to roll this up. Check for any tenderness on the kidney area. So use your whole hand and plant it firmly here, and then you strike and percuss with your fist. And then I'm going to come in on this side and do the same thing. And this is for places that are hard to palpate, like the kidneys. And if there's any tenderness there, it could indicate a kidney infection, any hydronephrosis, or kidney stones. Okay, you can lay back down. Thank you. I don't worry about that part. And then for the bladder, you can percuss down lower over the bladder, but usually you can't. But if the bladder is empty, you might not get the same percussion sounds, but you can just percuss in general in that area and see if you get any changes in sound, but an empty bladder might not be percussible. And the next step is palpation. You first start with light palpation. This serves several purposes. It helps just to note for any tender areas of the abdomen, helps get the patient used to your cold hands, gets out any giggles, and will help you note if they have any muscle resistance or guarding. So you just use your fingertips and start in one quadrant and work your way around, and just gently palpate all the way around and assess for any tenderness or muscle resistance. And then for deep palpation, you use the palmar surface of your hand, and you compress about 5 to 6 centimeters. You can usually feel the colon, a full bladder, liver borders, and the spleen. And while you're palpating, you want to note any masses, their size and location, or any tenderness, anything like that. So I'm just going to do deep percussion. If I'm pushing too hard, let me know. Deep palpation. I said percussion, but this is deep palpation. And then you want to palpate specifically around the umbilicus and note if there's any swelling or bulging or masses. Could be indicating an umbilical hernia, but it all looks normal here. And then you're going to also palpate the aorta. And with your thumb and first finger, you're going to feel just left of the umbilicus. You can feel the pulsing aorta and try and palpate both sides of it. I need to shift in a little bit. And Kimmy's aorta is about 2.5 centimeters, which is normal. 2.5 to 3 centimeters for an aorta is normal. If it's wider than that, it could indicate like an aortic aneurysm or some other complication. Let's see, you can also palpate the liver, the borders, by 2 methods, or at least the lower liver border by 2 methods. You can do bimanual, where you put one hand up high and one hand right under the costal margin and have the patient take a deep breath inward. and you can push kind of up underneath the ribs there to be able to fill the lower liver border, or you can do what's called the hook method, where you stand on the side and use both hands on the right upper quadrant here, and same thing when they inhale, you kind of hook your fingers in and under that lower costal margin to palpate the lower border of the liver. For the urinary bladder, if it's full, you might be able to palpate it, but if it's empty, it is not palpable. So in this case, it is not palpable either. You can also do a couple tests to rule out ascites, appendicitis, or cholecystitis with palpation. So the first one for ascites is called testing for shifting dullness. So you start by percussing from the flanks inward towards the belly button and assess where the sound changes from dullness to tympany. So we'll do it on this side so the camera can see. Percuss going inward. And assess where it changes, and then do it again on this side. And that's, okay, so it's about there are our borders. And then you have the patient roll to their left side. I'm gonna make you move one more time. And you repeat the same test. So from the flank going inward, assess where it goes. So right here is where it shifts from dullness to tympany, and then you do it from that lower side coming up. And if that's about the same borders where we heard the change the first time, if the change is significantly different or shifted, it's because there's a lot of fluid in the abdomen from ascites, and so it's changing where you hear that shift from tympany to dullness. But on Kimmy, it's the same border. Okay, you can go back on your back. This is the last time you have to move. Okay, you can do other tests for ascites. The other one is called the wave test. This one you would need a third or a second person to come help you, and your helper would put their hand right down the center of the abdomen with their ulnar palmar side down the center of the abdomen, and then I would use my left palm and place it on the right side of her abdomen, and then on this far side I would tap, and when you tap, the person in the middle is using their hand to assess for any fluid wave hitting their hand. And if they feel that wave when you tap, it's because there's an abnormally large amount of fluid, which would indicate ascites as well. A couple of the tests for appendicitis, the most common one is called checking for rebound tenderness, also known as Bloomberg's sign. When you do this one, you palpate deeply at about 90 degrees over this right lower quadrant where the appendix sits, and you press firmly and then release quickly, and ask the patient if it hurts more when you're pressing or when you release. And if they state that it hurts more when you release that pressure, that's the rebound tenderness, and you would have a positive Bloomberg sign. You can also check for referred rebound tenderness, where you do the same type of palpation on the lower left quadrant, and if when you release it's tender on the right lower quadrant, that could also indicate appendicitis. Other tests include the psoas sign, where you have the patient lay on their left side, you hyperextend their right leg behind them and check for that right lower quadrant pain, or the obturator sign, where you would pick up the patient's knee, bend their knee, and then do an internal and external rotation. And if that had any right lower quadrant tenderness, those could both indicate appendicitis. You can also do the hypersensitivity test, where you use a sharp object like a tongue depressor broken in half or the edge of your pen, and you would just stroke on that right lower quadrant. Or you can pinch like an amount of skin, grab some abdominal skin, and assess for any exaggerated sensations in that area when you do those tests. The final test is called Murphy sign, and it is used to assess for cholecystitis, and that's in the right upper quadrant where that gallbladder sits. You press your fingertips under the liver border on that right upper quadrant at the costal margin and have the patient inhale deeply. And if there's no increase in pain, then it's a negative Murphy sign. Usually when it's a negative sign, the patient exhales normally, just like Kimmy did. If they hold their breath and you're doing that palpation and they keep holding their breath and don't want to exhale, then that's a positive Murphy sign as they hold their breath associated with the pain, and that could indicate acute cholecystitis. And that sums up our abdominal assessment, so thank you for watching.